So I want to talk about Pennsylvania's project. This is really the effort that has been going on for about 5 years. We're in the middle of a second round of a SAMHSA grant and preparing to apply for the third round. As I said before, we're the only state that's using Garrett Lee Smith dollars to specifically look at primary care, so we're hoping they're happy with us and interested and continue to fund the project, and we'll continue to expand out in the where we're going to be. In the first round of the grant, we were primarily focused in Schuylkill, Luzerne, and Lackawanna counties. Those are the counties that have the highest suicide rates in the state, and we did the work up there in about 10 primary care sites. In the second round of the grant, we've moved both to Philadelphia and to the West Coast. We're in Allegheny and Westmoreland out there and expanding out from here. And then we're in all 5 counties in this area. These grants come through the State Department, and then they get sent out and contracted to people around the state who can run the grant. So that's how we're operating. So there's 4 assumptions of our work that guide what we're doing. And that is that screening for mental health problems allows for early identification of children and adolescents at risks. We're hoping that can, as David alluded to, improve care and reduce costs. We're interested in reducing referrals to the emergency room, reducing referrals to inpatient settings, and to try to handle more of these problems on an outpatient basis by identifying kids early on in the development of psychopathology and problems. A second assumption for us is that screening for suicide should take place in the context of screening for general mental health problems. Lots of kids who, the main movement in the field right now is screen for depression. That's been approved by the National Task Force. Everyone thinks it's a good thing. There's enough studies to show that if you do screen, you increase identification rates. So the National Task Force, Prevention Task Force says we should be screening in primary care for depression. This recent task force report came out saying there's not enough data to support we should be screening for suicide. Not that it's not a problem or it's not an important thing to do, there's just not enough studies to show that if you add a suicide measure into a primary care setting, that it'll increase the identification rates above and beyond what a good clinician would find anyway. So we're trying to develop some studies that might address that. But even with that, our experience is lots of kids who are suicidal are not depressed. And if you only screen for depression, you're going to be missing a lot of things. So a lot of places that use the PHQ-9, which is certainly getting the most legs. Is everyone familiar with that tool? It's a 9-item sort of depression, distress, kind of functional impairment kind of questionnaire. It's in the public domain, so it's been picked up by a lot of institutions as the main effort to do depression and screening. There's a 2-item version, and then if you say yes, you can do a 9-item version. So it has a nice short framework to it, and I think we're going to hear more about it, what's going on in Western Psych. Our experience is there's a lot more going on for our kids. We want to screen more broadly. There's kids with problems with substance abuse, anxiety, suicide that aren't going to get tapped by a single or 2 depression items. The third assumption behind our model is that, and as I said earlier, introducing a screening tool into requires a much broader systems change, and that's what we're going to hear about all these projects, that you need to do work on the front end, educating doctors about mental health. A lot of primary care providers, nurses, doctors, they don't get very much training on mental health in medical school, and other people can attest to this more than I can. I'm a psychologist, but the level of training, the level of attention to suicide risk assessment is relatively non-existent in medical school. These people have great interviewing skills, have acquired good knowledge, but often don't feel like they have a concrete set of skills. So we think a lot about training on the front end. And then obviously, as more cases are identified, there needs to be a system where those kids can get in access to care more easily. Without that, primary care says, we're not going to screen. These are hard enough for us to begin with. Why should I increase the identification rates when I'm then going to be backlogged with trying to refer kids? So doctors, primary care providers say, solve all these problems, and I'm willing to screen. Particularly if we could get reimbursement for screening, which I know we're going to hear a little bit about, because for me, I think it's the final barrier that holds back a lot of primary care offices from moving forward on this agenda. The fourth assumption for us was, how could we use technology to make some of these processes go more easily? And that's particularly around the screening tool, and we've talked about that a little bit, but that's a main emphasis from our study. So these are the assumptions that guided our work. As I said earlier, in order to address these things, we had 4 central aims of the grant, and continue to have. As David said earlier, this is a stakeholder project. If you don't have broad buy-in from a wide range of organizations and leadership, it's going to be much harder. So we're interested in stakeholder development. We're interested in trying to improve coordination and communication between behavioral health services and medical services. We're interested in doing gatekeeper training for medical providers, and then we're interested in using the web-based tool. And this is the 4 pieces of the grant that we do. So I'm going to just talk a little bit about our efforts at each of these levels. Some of them it's just sort of common sense things, but it's the package that we try to sell to people. If you don't approach a more comprehensive model like this, the likelihood of failure and resistance is much higher. So we were interested in stakeholder development and have been lucky enough the grant goes through the Department of Welfare. So we have at the top of the project welfare and the Department of Health. We have partnered closely with the 4 medical associations in the state. We have a monthly phone call with them. They invite us to meetings. They help do distribution, pediatrics, family physicians, nurse coalitions. We've created very strong relationships with them, and that has given us a lot of credibility as we roll out the project in a variety of settings. We've partnered with behavioral health organizations, particularly with the Pennsylvania Community Providers Association. It's a large advocacy group for behavioral health, but 500 agencies sit at their table and they're represented by. So that's been helpful to have them at the table. We have a monthly phone call with Medicaid and talk to the people at Access Plus and Community Care. When we first got this grant, it was the 2008. And they said, sorry, Dr. Diamond, had you come a year ago, we would have been happy to, reimburse for screening and done all kinds of creative things. In this current climate, we're very strapped for cash. But still, they've continued to be at the table. And Dave Kelly actually finally called us the other day and said, I heard about this screening tool. We're trying to think about how to do these things. So it's a sort of a timely kind of thing. But we're trying to operate at a high level, try to be at meetings where people are planning how to organize services and trying to maintain support for the project. Let me see. Actually, I want to go back. That's been at the sort of state level, but we've also done similar organizing at the local, particularly at the county level. So the grant has always gone from the Department of Welfare into the county director for mental health services. They've partnered with us. They've assigned somebody to be the main liaison to help us go out and find practices and then help link the medical practices with the behavioral health. Many of the counties we're in have suicide task forces. If any of you sit on any of these are great organizations that usually already involve police, schools, emergency room, churches, community. People have come together, have a lot of community influence, And they sit on within each county, we have a task force that helps guide the work so that we have local stakeholders that are helping to move things forward. And that's been very helpful. This isn't going forward so easy, backwards so easy. We did a survey of the state, about 600 PCP providers, nurses, doctors, primary care services, to try to figure out what was sort of the needs, what are their needs, what are they, how much suicide do they see, and what are their mental health needs. What we found was 78% said that they referred at least one patient for a suicide ideation or attempt in the past year. I've been at meetings, it's been interesting, where I've asked how many practices have had a suicidal kid in the last year, and I get about 5 hands to go up. And then you ask, well, how many of you have had a kid with severe depression in the last year? And 80% hands go up. So depression for us has been an entry into primary care. Everybody's worried about suicide, there's no question about it, but depression is a more meaningful issue in the primary care world, and so that's one other reason that the screening tool has tried to be a broad base to try to appeal to a lot of different needs in that way. Most practices reported they have no mental health provider in their service. So I know at CHOP we have many of our practices, at least closer to the hospital, have social workers. We're going to hear about that later on. As even in the CHOP system, the further out you get into the practice network of about 35, 40 practices, fewer of them have mental health providers. And when you get out into the counties, very few people have anybody co-located within their office to handle mental health services. 45% reported that they couldn't get services quickly, that the lines were long, waiting lists were long, or people didn't have insurance. And 24% report that the MH provider let them know if patients went. This is one of the biggest complaints by the medical community is, I refer a patient to behavioral health and I never hear back. And the behavioral health community sort of struggles with HIPAA and confidentiality and can I release this information, and the lack of communication back and forth between these organizations is remarkable. Jack McGee at Chestnut Hill has done a lot of work to partner with the local organization. They have a monthly meeting, as I said earlier. They've worked out forms. They've worked out paperwork. Jack's been pushing to have one form regardless of which behavioral health center they refer to, trying to streamline, clarify, make communication more easy for the medical office to be able to connect with. So we've done a lot of work on coordination to try to improve relationships, improve information exchange between the PCP and behavioral health. Some of it has been to educate here in Philly. That's not as much of an issue. Out in the outer counties, it was remarkable how poor the medical providers' knowledge was of the mental health community. They knew crisis, they knew the main community mental health centers, but they didn't have phone numbers. The story I always tell is we were sitting in Scranton at a large health center that was in the center of downtown. 4 blocks away was the large community mental health center where they'd been referring people for 20 years. So I said, great, who knows anybody over there? Do you have a relationship? And the 12 doctors sitting around said, I don't know anybody. I don't know anyone by name. Staff changes. We don't know. All we have is a phone number. We don't know anybody. We have no relationship with these people. And that has really been sort of an indicative symbol of what we've struggled with throughout the counties and throughout the projects. So, we have been doing some simple things as inviting behavioral health providers into the medical offices. We've had wine and cheese parties. We've sent out letters. We basically say this medical practice is going to begin screening, which means there's going to be an increase in cases that need treatment. if you're interested in more referrals, please come to this meet and greet and sign up and fill out some forms. And then we say to them, we'll send cases to you if you promise, to whatever degree we can, to give feedback, provide information, be available by phone. And so we sort of use the business incentive to try to increase the interest in trying to communicate back and forth. We've created directories. I know all us behavioral health people, we've always had mental health directories on our desk, big giant books that go out of date every 3 years. And mental health, the medical community doesn't have this. They don't have we've made simple one-page laminated list for doctors. Here's crisis, here's the 3 mental health agencies, here's 4 private practice doctors who are willing to see your cases. And this was revolutionary for them, something as simple as having easy access to referrals. We now have the ability to send the BHS report to the behavioral health community. So when a kid gets identified and we're going to refer them, there's a very easy process with appropriate HIPAA releases to be able to send the report so that what was evaluated here in the office can go to the behavioral health doctor, so there's some continuity of care. And these are just the kinds of things we're just trying to build connection, communication, and relationship. Sometimes it's been very successful, very helpful. Most doctors report they can now get people into services more often and feel like they have a better collaboration with with the mental health providers. Another part of what we've done is focused on training, trying to provide and find an adequate way to train mental health providers. In New York, there's a program called Project Reach. It's done by Peter Jensen. Tremendous program. It's a 6-month. You sign up for 6 months and 3.5 hours a week. I don't want to badmouth them, but it's a very intensive mental health training for primary care docs. And I've never met a primary care doc who says, oh, yeah, we're going to do this. This sounds like a great idea. But it is expanding. What we decided was we need something that can be done in an hour. It can be done at lunchtime, and somebody can log on. Initially, Matt Winterstein, who led the development of it, used to go to the sites. Now we have a 1-hour talk that's on a website. You can look at it anytime you want. And what did we find? PCP said they had very little training. 50% in our survey said they didn't feel competent to do diagnostic work with depression and suicide. They felt that they didn't feel competent, they didn't feel capable of doing this. So we developed through the American Suicide Association, with Matt's help, developed a 1-hour in-service. It's available outside of our project as well. It's now on the web. You can log on and you pay a small fee and watch a videotape. Some of it's Matt giving a lecture on suicide risk assessment, a little more clinically oriented than today's talk, and a couple of vignettes of how to talk to kids about suicide. And the medical providers love it. Anybody here watched it? Anybody? Give me a testimonial here. I know, Jack, some of you said. It's remarkable how I still go up to Scranton and people say, you know that little hour training you gave me a year ago? It still helps me. It gave me something a framework to use. So it covers a lot of relevant material. It's about a 90-minute talk. It includes lectures, videos, covers suicide risk assessment, triage, crisis response planning, intervention for primary care, and how to document some of these things. So it's nice and short. It's a very helpful tool. We're going to go forward and develop some additional training tapes, and again, trying to map into the primary care world. We're going to do 15-minute lectures, 15 minutes on depression, a 15-minute talk on substance use, a 15-minute talk on family engagement. So the docs who are very busy, we know how busy you are, can sit down with their ham sandwich and log on, watch this, get some education, and go back to their daily work. It's trying to fit education into the primary care world is a very challenging thing. These offices are very busy and a lot of demands. We've done some other trainings too, but I'm going to pass over those. So we do some resource development, try to improve their access to services. We do some training and education with the providers so that they feel more comfortable and capable. And then we move into our screening project. As I said earlier, our tool is a broad-based tool. It screens for risk behaviors as well as psychiatric problems. We've done some very nice validation studies, so it's well validated and has good psychometrics. It screens, one of the things we like about screening tools is it standardizes the questions so that everybody gets the same suicide question, and it standardizes the assessment across providers, because some providers feel comfortable asking about child sex abuse and some don't, and some feel comfortable talking about sexual orientation and some don't. But when you use a tool like this, everybody's getting the same set of questions that have been validated and worked out. And whether it's the PHQ-9 or our tool, this is really a strong value in trying to cover this, use a tool like this. It takes about 7 to 10 minutes, though, as Jack was saying, trying to fit it into workflow may involve a more involved procedure, getting the kids signed on, getting them logged in, printing it out afterwards, all these things. Now, this would go on with any kind of tool you use. Our experience is trying to introduce a screening tool like this into the workflow of primary care is no simple task. Who's going to do the screening? Where is it going to happen? How is it going to get into medical records? These are not small problems and definitely need a lot of attention and work to think through. We actually now have an adult version of the screening tool. It's a similar questions used took out some of the adolescent questions. So we can actually now, with a tool, screen from 12 till death. And again, what we were thinking is primary care would like to have, they like it simple, they like it clear. Having one tool that can screen everybody is an asset to them rather than having to log in and out for other kinds of tools. So that's one of the additions. Also, many doctors use our tool to repeat evaluations. So they see a kid in October, and then they're depressed, they refer them for services, they re-administer the screen in December, and as you'll see there, we have some charts that show how they come out, how the changes over time. These are the domains that get evaluated, and again, these are following best practice guidelines. We have questions on gun access, we have questions on bullying, and as well as a variety of other things. This isn't a good snap. Here's some of the reports that get generated. So if you have a patient going on its own, these are charts that get generated about patient change over time, so that if you screen a kid twice, the system will generate a screen that will give you some changes over time. You can see how the trends go. One of the things that excites us about this tool is the ability to aggregate it. I'm still becoming familiar with it, but apparently a pediatrician has to do a QI study every 4 years now, right? Is that it? 3 years in order to renew their license. And this is a perfect kind of project, and we've been working with the Pennsylvania Academy of Pediatrics to try to turn this into a QI program so that this, while they're implementing suicide screening, they're also satisfying other sort of licensure needs and generate reports that would suffice for that. So it's really has some nice benefits in that way. There's very good psychometrics on the study, on the screen, certainly comparable to other things. We've put it up against the Beck Depression Inventory, and it's more than adequate for psychometrics, and there's a nice paper in Pediatrics published on that. This is actually a better picture of what the screening report looks like. So you see there's critical items at the top, and then the scaled scores, then there's risk behaviors, and then patient strengths. This is the front page of the printout. Behind that we print out all the items that are endorsed and or scored, partly for medical medical records reasons. People and all the docs want you. If you get a yes on depression, you can turn to page 2 and sort of see, well, what are they saying about depression? Allows you to drill down. This report comes down in a PDF file and can be copied into a medical record, electronic medical record system. Some places have been interested in trying to build a patch so that this just automatically goes in, or in fact the raw data goes in. I don't know, I'm curious to hear how they're doing at Western Psych. We actually find this is more than adequate to put the report in, particularly because the data is being housed in a HIPAA-compliant warehouse in Baltimore that you as a site have access to all the time anyway. So if you want to go back and find Johnny's report from last year, you want to run a report on all the patients you've seen in the last year, you have access to all that data. And in fact, to put it into your Epic system will make it much more difficult to try to get access to it and manipulate it in any way. So there's sort of pros and cons in both regards. This is basically the workflow. Patient comes in, registers at the front desk, nurse or front desk sign them up. It's like logging on to Facebook, what's your name, what's your ID, what's your birth date, up pops the screen. Patient number 3 fills out the screen in about 10 minutes. When they're done, the screen prints out in the nursing station in the back room. Doctor reviews the information before meeting with the patient and uses it to guide the clinical interview, puts it in the chart, copies it into the chart, and what we're hoping is eventually this will be a billable service. These are some other things. Because it's a web-based tool, it has a lot of functionality that we're trying to develop. We're going to be able to put other measures into the tool. I know there's a lot of interest in early childhood autism screening, and that could live on the same platform. We're trying to develop the back end of screening. We have a couple grants under review that would allow us to build a searchable resource database. We have it here at CHOP, actually in the ED where it's being used, where the doctor can put in the name, the address of where they live, and type of insurance, and up pops 3 referral sources. Given their insurance type, here's places and the doctors feel like this is a heaven-sent gift. It's amazing how helpful that's been to them. We're trying to build text messages that we can, so after a patient's been referred, we can automatically send a text a week later. Don't forget about your appointment. Did you remember to go? Could you let us know if you went? And try to use it as an ongoing communication system. In Philadelphia, there's also, we've written grants to try to do it formally, but what's emerging is many primary care sites are using the tool, many emergency rooms are using the tool, and some behavioral health centers are beginning to use the tool. So suddenly there's this sort of communication highway going on between these systems of care where there's an ability to exchange information and give back and forth information about it. People know the teen screen. It's a well-known tool that's similar to ours, and unfortunately it has been closed down, so it's not as available. So here's just a little snapshot of what we've done. We've screened now it's up to about 3,500 in the primary care settings. At CHOP, we've screened about 12,000 kids in the emergency room, so the numbers are growing every day. But of the about 2,500, about 12% have endorsed thoughts of killing themselves sometime in their life. It's a pretty general question, but certainly for us, a question that indicates a kid should be evaluated. 3.7% reported current ideation. Sometimes providers would say, oh, if I start screening, I'm going to be inundated with suicidal kids. And what we're really finding, and this is confirmed in a couple of other studies, about 4% of your population might show up with some pretty serious ideation. Interestingly, about 8% were already in treatment, 21% we tried to refer, they didn't want to go, and about 44% we were able to refer, and they actually went to services. We've been tracking them. This, again, is sort of how it breaks down. Out of this 2,300, about 15% felt they'd been suicidal sometime in their life. 37% reported some level of depression. Trauma, 22%. Substance use, well, we're finding is a bit low. We're always thinking we have to go back and interview kids. We're worried they're underreporting on that. But these are the general numbers that we tend to see. One of our questions is, do you have access to a gun? And if you say yes to that, and you say yes that I've been thinking about suicide, both those items come to the front page as a critical item. So you, as a medical provider, if you get a kid who says, I'm thinking of suicide, and there's a gun in my home, those are serious issues that one needs to deal with at that time. So it looks like 18% of the kids who endorsed a history of suicide said they had access to a gun, but 12% of the kids who said, I'm currently feeling suicidal, said there's a gun in my home. That's a serious combination that we're very worried about, and this tool kind of gives you that information instantly. We've been looking at cutters. We know there's a complicated issue of when a kid who cuts all the time, is that suicide? Are they at risk for suicide? And actually what we found is that a lot of kids, when there's definitely kids who cut are more severe than kids that don't cut. That would make sense. But kids who cut and don't have suicide ideation are at less risk for attempts. But if you get kids who are cutters who have ideation, and on another slide I don't have, if they have substance use going on, they are much more likely to attempt. So it's just we're trying to use the data to find out risk profiles that help us look at them. The study we did here at CHOP I think is interesting for dissemination purposes and thinking about, this was really a sustainability study. Most studies that go into particularly emergency rooms or even medical settings put a research assistant into the setting and say, here, we'll screen for you and we'll sort of find out what the prevalence rates are. Our study, as was Joel Fine's study, was more of an attempt of, here, we're going to give you this tool and we're going to see if we can integrate it into your service. Can you adopt this as a process? And in that study, by the end of a 2-year grant period, 33% of eligible patients were being screened. Since that time, the CHOPS ED has embraced the tool at a much higher level. There's much more investment in it. JACO came one day and saw the tool being used and said, this is a perfect patient safety procedure. This is exactly what we want to see. And suddenly Steve Altshuler is writing checks to say, make sure this keeps going on. This is how history determines what really happens. So we're now up to a 60% penetration rate. They're screening almost 400 kids a month in the emergency room currently at Children's Hospital. So we're really pretty happy with how things are going there. When we've done some satisfaction questionnaires with providers, about 92% say they really like the overall model. It's clear that you need a point person, a champion in a practice who's going to push this forward. There are all kinds of ripple effects within a practice, and you need someone to lead it. If PCPs increase screening, they'll increase identification rates. And mental health providers will be more interested in coordinating, if not co-locating services. In our project up in Scranton, in fact, even here in Philly, I was telling you, there's a city health center that used to have a partnership with one of the local mental health centers, and they would send someone over 2 afternoons a week to kind of do evaluations, and they never got referrals. And after about 2 years, they said, it's just not worth our time. We're not generating enough money. But what we also knew is that they weren't screening at that time. And I think what we do, if we could get the medical setting to screen more, we think it would create more of a business opportunity for co-location to be valuable to mental health providers. The final barrier that we have is really the reimbursement issue. Everything a medical provider does, they get paid for as they should. for this, they're not getting paid yet. You can't get reimbursement for mental health screening. Most doctors say once that changes, I would screen twice as much as what I'm doing. It's just a real barrier. I know in Massachusetts, and one of the reasons I was interested in bringing someone down from there is I hope maybe you have a different version of it, but there became a mandate to screen. I don't want to scoop your story, and initially the state started screening about 30%. This is what we read. And then a couple of years later, reimbursement for screening was introduced, and penetration went up to about 60 to 70%.
Around 80%.
80%. With the addition of reimbursement, screening just took off. And
the privates are reimbursing too.
And the privates as well. In fact, I got from him the information because I'm using it here in Pennsylvania. The privates pay 15, and the Medicaid pays 10 for a screen. So we'll hear more about it. So that's something that we're really, in the next go-around of the grant, going to really push as an advocacy because we think that would help push forward. So I'm going to stop there and take a few questions and